Between 1 in 5 and 1 in 10 people have IBS. Okay.
Really?
Yes. 30% of those will have a depressive or anxiety or panic-led foundation that has led to the condition. We tend to find actually, when you're talking about the gut brain, the gut in itself is a system, an ecosystem on its own, but it's linked also physically with the vagus nerve. The way that I always try and explain the gut-brain axis is just think of it as a bidirectional communicative system. So we tend to find, and we've seen with data, patients with IBS that have gone through vagus nerve dampening exercise, the simplest thing like yoga or breath work, their symptoms resolve or reduce, and they get to the point where they can say, I'm in remission.
Welcome back to Mind Movers, the mental health podcast in dentistry. I'm just going to say that, this is the mental health podcast. For anyone that comes second, we have first mover advantage. Today I have Dr. Sunni, who is an award-winning ultimate health and wellness coach and a lifestyle medicine practitioner with a special interest in gut health. My journey with Dr. Sunni started a few years ago. I have always suffered with IBS, I've always suffered with gut problems, and I was constantly getting ill at this period of time. It was actually after COVID. I was really suffering. I think I got ill about once a month. I had flu about once a month after COVID. And I love when people are like, COVID's not real. I'm like, it's real. I definitely got sick all the time. Anyway, someone that Dr. Sunni knows had approached me on Instagram, and he said, listen, Dr. Sunni's amazing. He works specifically with the gut. Let me do an introduction. You might want to work with him. When I met him, it was an instant connection. I thought he was amazing, brilliant, and wonderful. He tackled gut health from a very holistic perspective, definitely changed my life. Some of the benefits that I gained from working with him were, increase in my mental health and wellness. He introduced me to Ella as well, dealing with trauma issues, which were also indirectly affecting my gut. More balanced approach to eating. I eat chocolate every day. And also just haven't been ill in a really long time as well, which is fantastic. I'd say that I get ill once every kind of 4 or 5 months, which is massive for me. Obviously, ideally won't get ill often at all, but it's a massive thing for me. And also just having a much better relationship with food and accepting those times that I choose to go out of the foods that are good for me, and accepting those bloating periods, etc. So without further ado, here is Dr. Sunni. Thank you for coming on today.
Hello, well, thank you so much for having me. I feel so humbled when you introduce me, Rhona, every time, because I do remember the first time we spoke.
Yeah.
You may not remember, you were having your hair done at the time.
Oh God, classic Rhona multitasking.
Yeah, it is a classic. And I remember you just saying, actually, I just want to speak to someone that listens to me. Yeah. And we had such a heartfelt discussion. And it really highlighted the reason why I do this is because it's about medical gaslighting, and you speak a lot about medical gaslighting. And I find that with gut health and issues. So I was really humbled to help support you, and you've become such an advocate. So thank you for having me on this podcast. Really, it's an honor.
Well, we're really excited. So do you know about medical gaslighting, Payman? Can you guess? He's not very woke, by the way, so I've just got to tell you. Yeah, he's not like us.
Be ready.
Yeah, exactly.
Explain it, girl.
It happens all the time, medical gaslighting, in dentistry as well. So it's when someone comes to you presenting a list of symptoms or complaints, and because you can't physically see it, so it's very common, obviously, in medicine, where you're like, well, your x-rays are fine. Well, I can't see anything in the mouth. So you discount what they're saying and tell them it's nothing and it's all in their head, essentially, So you kind of blame some sort of psychosomatic reasoning. Now, as medicine's developed, as you know, we understand that it's very multifactorial, and we're not just dealing with the anatomy of the human body, but we're also dealing with mind, stress, fitness, food, etc. So I found that every time I went to a doctor, specifically gastroenterologist, and said my stomach hurts, I have pain, I have bloating, I have all these symptoms, they do an endoscopy, they do all these tests and nothing could be found. They were like, what's in your head? Just manage your diet. And I always felt like I wasn't heard. So as I was saying, when I spoke to Dr. Sunni, which also should happen in dentistry, you really need to listen to people's symptoms and try to find out why they're feeling the way that they do.
It's in your head kind of means stress. It's a stress related.
No, it's in your head as in there's nothing there.
Oh, there's nothing.
Psychosomatic.
Yeah.
It's a placebo effect of kind of hypochondria, essentially.
Yeah. Correct. You're hypochondriac.
And you tend to find it, if you look at data around there, the outpatient departments that are the most stretched or longer waiting lists you tend to find that's where patients will go privately, and the first symptom or the issue they'll say is, I've come to you or I've come privately because I felt I wasn't heard by the doctor. Now, that's not discounting the profession, but essentially the medical systems are almost taught, look at patients almost like a textbook. If these are the presenting symptoms and they don't tick box, and I didn't do that, and that's the issue. The minute Rhona and I connected, I just had that emotional connection with her, because I could just hear someone that's saying, I just want someone to hear what I'm going through, and this bloating isn't a phantom symptom. And it is sometimes phantomized, and that's the issue. I find 99% of my clients are all people that have just said, no one's heard me. And this happens in the private space as well, because again, in the medical and healthcare profession, we tend to always just focus on the symptoms. So we just think, okay, well, it's bloating, so you must take this. This is a protocol for IBS, or there's a blanket diagnosis, it must be IBS. If it's not known, IBS it is. But actually, sometimes just taking that time, to Rhona's point, listening to the patient/client, you already get a nuance and an understanding of where their mindset and emotional mindset is. And it was straight away, and I said to Rhona, I think we just need to do a kind of more of a holistic support and management. It's not just, a medical intervention. Let's really do an emotional and mental intervention as well. But again, it's because the system's not set up for that multidisciplinary. We try to say we're multidisciplinary in nature, but really we're just, the burden of the system doesn't allow that.
So let's start from the beginning, right? Because we always, what's always fascinating to me is how people end up at this point. So tell me, what was your career before and what led you to where you are now?
Do you really want to know? It's because it's a very long and varied story. So I actually started as a humble optometrist.
Oh, really?
Yeah, so optometry is my field. And then I upgraded or moved over to ophthalmology. And I was a researcher, an academic and lecturer. So I'm a geek by nature, but I'm a perpetual student. Unfortunately, we were talking about NHS and medical systems. The academic system also, I felt, was just not really fulfilling what I wanted. So I traveled around the world doing corporate global research, kind of commercial work, medical affairs, to the point where I had to take a stop. So the issue why I kind of really focus on gut health is because I have Crohn's and colitis, and I've had it for quite some time. I was medically gaslit, and I don't think that was because of the consultant. I just think the system was set such that, again, you don't tick all these bullet points. You aren't my typical type of client or presenting patient. Interestingly, I went privately first. And private care was brilliant. I had my colonoscopy within a week. I had all my blood tests. The consultant was very, communicative, very engaging. And then, the minute you meet your 10 appointments, and they're like, well, what would you like to do? Would you like to continue privately and pay? Would you like to go back to the NHS system? I went to the NHS system, and the care just completely changed. It was just non-existent. That already started making me thinking, well, I've changed now from a clinician to a patient, and I'm seeing all the leakage points on the patient journey, and it was just frustrating, to the point where whenever I had my outpatient appointments, I just stayed quiet. There was no point me even saying I was flaring up, because I just thought the minute I said I was flaring up, he would just say, well, just ride it out. So from the first colonoscopy I had from diagnosis, it was 7 years till I had my second colonoscopy.
Wow.
And it was only because I called my consultant and I said, I've spoken to a private GP. The private GP has put me on steroids. And then he said, and the minute he knew that I'd gone outside of the system, I had a capsule endoscopy, I had a sigmoidoscopy, I had a colonoscopy, I had every single diagnostic test possible. And they said, okay, we do need to consider your management. Fast forward, fortunately in lockdown, and you mentioned COVID, I had bouts of COVID, but my COVID story is that I was hospitalized during lockdown 2.0.
Really?
Yeah, and I was hospitalized twice. We always talk about patient compliance. Practitioner compliance is the worst. So I was hospitalized for severe symptoms. It had been lingering for a week and a half. I just, male machismo, pride, whatever it is you want to put it down to, I labored it to the point where I had to go to A&E. The nurse that admitted me had said, unfortunately, you are going to have to be admitted today. And I just broke down and cried. I was like, I am not going to be a system and a subject of inpatient. I don't mind being an outpatient, but just something triggered me. I'm like, I cannot be an inpatient. And also there's people more deserved of the space. This is lockdown 2.0.
Yeah. My
bed is probably going to be worthy for someone that has pneumonia or other things that needs it. And she was, no, you need to be in hospital. I was discharged in a few days. I was given morphine. That's how severe it was. I was actually on morphine. 4 weeks later, I was admitted again because I wasn't compliant. I thought I had to be productive. And this is the thing, we're almost ingrained as healthcare professionals. We don't know how to stop.
Yeah, I know.
We never think about our own health or presenting symptoms. We think we'll ride it out. We know better than everyone. It's sometimes a God complex. And I was admitted again. And it was through that journey I met a fantastic gastroenterologist who sat down next to me. And he actually asked me, what is it that you'd like? What do you want us to do? And I was taken aback because I was like, this has never been presented to me before. It's always been, well, we'll do this because we have to or we must do. Your bloods aren't presenting what your symptoms are saying, so we'll just see you in 6 months. And he actually put me onto a community course that he was leading. So he's a very forward-thinking gastroenterologist, and he's trained in the teachings of Kabat-Zinn around mindful eating, early aspects of lifestyle medicine. And it was more like group therapy and coaching.
Yeah.
And we shared our pain. And for me, that dampened down a lot of my subconscious thoughts around my condition, the shame, but also the hyper escalation of the symptoms. Because then you meet other people and you start rationalizing, you start thinking, well, actually, I'm not as bad as this person. I'm probably worse than this person. And it allowed me to become more empowered. So I left work. I left a fantastic six-figure salary. I was getting the bonuses, the cars, flying around the world. And I just thought, no, sod it. I'm going to drop it all. I quit. And I decided I would retrain in nutrition, lifestyle medicine, eating addiction, and set up my clinic just thinking that I'm going to help people so that they don't have to go through what I had to go through. Because we know that men in the healthcare system go through dark times, but we're also seeing, and I see a lot more now, even women in the healthcare system are going through dark times because we're just not being heard as patients. So that's why it's a long story. How I got there and what I done, it's from an optometry to lifestyle medicine. This is the beauty of the world we live in.
I love that so much, and I think like that's one of the big reasons Payman and I started what we started, because there was such a stigma around mental health and dentistry, because I think we view ourselves as healers within the kind of medical health sphere, and we view ourselves as those that help other people and cure them. So the moment we're not feeling good, whether that's physical or mental, we just kind of want to like suck it up, you know. Whereas I've learned now to be like, I am suffering. Last week, so as you know, the conflict is very topical at the moment. I'm Middle Eastern, and my grandfather's actually Palestinian Lebanese, and we've got family in Palestine. And that's why I said to you, there was a few people that I work with that were not understanding what I was going through. So I had to say, I'm not doing well. My mum's got family in Haifa, which is in Palestine. Like, she's really worried and really stressed. I can't focus. I literally can't focus at the moment. And it was really hard for me to say that because I felt like I wasn't being heard. And it's just like, I had to just say it and just say like, I can't do anything this week. And that's just the way that I'm going. So I think that that's a really important thing to take on. And I think, like you said, you know, we also have to not gaslight each other and it shouldn't be just like a toughen up. However, do you think that's because by nature, we're very ambitious people, and in some ways being sick can be perceived as a weakness. So therefore we're really bad, you know, at sort of showing that empathy towards each other as healthcare professionals. Do you know what I mean?
Yeah.
Do you think that that's the case?
I think it's multifaceted. I think so I do a lot of neurobiological work because the gut and the brain are linked intrinsically. I think there's an element as healthcare professionals, we have a rescuer complex. So we almost feel by taking time out and not seeing patients or clients, we're not serving our purpose. I mean, a lot of dentists, I'm sure, will always say, well, actually, the reason why I went into dentistry is because I wanted to help or do X, Y, and Z. The minute you kind of take a step back, it's, well, I'm no longer the rescuer. And a lot of people identify with I am helping. And when you're taking a step back, it's almost like saying, well, I am no longer helping, I need help.
Yeah.
And that's when the ego and the saboteur kicks in. So I typically see, so I work with a lot of type A personalities and healthcare professionals.
What's a type A? Tell us.
Type A is you and I.
Oh, lol. Love that.
Yeah, you and I, the insomniacs, the overworking, the oversensitive, the over-emotional, the empaths, the ones that believe that we should be 10 steps ahead, and we're always constantly thinking about the next thing. And that's not to say that's differentiating ambition with actually sometimes what happens is we become the victims of our own ambition because we start the elements of the saboteur kicks in. So the judge comes in, the victim, the hypervigilant, because we judge ourselves more, and that's when we tend to find that we're probably more common on the neurodivergent spectrum, ADHD, those aspects, the insomnia's rife, the mood kind of issues around work being our primary goal. And so a lot of my type A personality clients, I really have to work with them from the bottom up and say, actually, sometimes it may be, as an example, I may say, well, Payman, I'm not actually talking to you, I'm talking to your judge. We need to name the judge, because the judge to me is saying, I am not allowed to be ill. But there may be a victim, there may be a trauma element, that maybe you had an experience that you were hospitalized when you were younger and you never want to go back to hospital, but there's still the victim. So then I'll be like, well, the victim Payman is now talking to me, and actually this is why you're reticent and holding back from actually saying, hands up, I need help and I need to stop doing what I'm doing. Because I think we forget, by helping ourselves, the most selfish thing you can ever do is the selfless thing you can do is being selfish. Because actually, by taking a step back, you're going to serve your patients in a far more deserved way than burning yourselves to the ground.
Totally, and I see that now, and I think that's one thing that I learned with you, because so we're going through a refurb at the clinic at the moment, and last week they shoved all my patients, like the ones we had to cancel. So there was like back-to-back consultations, and I loathed being there. But when I think about the times when I come back from holiday and how I perform, it's so much stronger, and I perform so much better when I have 3 patients in the day. Does that make sense? Rather than back-to-back. And I used to think, that I used to love putting a numerical value on success, and it was interesting because you said that you almost gave up a job that had monetary rewards for what you're doing now, but the fulfillment is so much stronger. And I think that that's really important, because I think I've done that as well. I could be making more money, but I choose not to, because I actually value my days off and my holidays now more than actually just doubling the income.
Look, I mean, everyone or a lot of people take a weekend, don't they? You could work, 7 days a week, but it makes sense not to do that. Now we go, as a dentist, I remember going from 5 days to 4 days.
I'm on 3, just so you know.
I'm on 0, but
Winner.
I remember going from 5 to 4, earning more on 4 days than on 5 days.
Yeah.
And actually having that 5th day to reflect and restart all this and so on. And so I think what you said about the NHS and private actually resonates a lot in dentistry too, because in the NHS system, dentistry, you just do not have time for extras. And extras being greeting people, talking to them, asking them about stress, asking them about family, asking them about sleep, for instance. And we have that issue as well. I mean, the TMJ, people grinding their teeth, is really, most of it is a stress related thing. And I've done it with patients. I tell patients, look, this is stress related, but that's all I say, because I'm not number one qualified, but number 2, haven't got the time to go, okay, let's talk about the stress. What can we do? Can I refer you to someone about the stress? And actually, it's that issue of when you tell a patient it's stress related, first thing is they get defensive.
But you know what? But also the funny thing is people don't value, as you were saying that, I was thinking people don't value conversations. I was willing to pay for a service with Sunni where I was also being heard, right? And that's obviously different to therapy, because we were talking about my gut related symptoms. But recently I got an email from someone saying, oh, I think my PA has got something wrong. She called the clinic and they said it was this amount for your consultation, just for a chat. And I was just like, just checking that's correct. It's fine if it is. And then, they make you feel guilty. But I'm like, this is not a chat. Like, you don't like your teeth. This is an hour of my time. This is an hour of collecting records and information. And I don't blame her, but I do blame the system in the UK that's basically put zero value into like diagnosis and fact finding, which is pretty much what you're saying. And as we have systems that are basically like tick boxing, right? As in, like you said, like, oh, I've got da-da-da-da-da-da. Can we find an immediate diagnosis? No. Do we want to spend money on an endoscopy or whatever to diagnose Crohn's? No, not at this point. No. Delay. Oh, what? There's a fire. Let's put out the fire. Now we'll throw some money at it. Exactly. That's pretty much the way the system works, I think, within the whole umbrella of healthcare.
I think in any discipline you see it. I think there's an aspect, you're right, Pam, we demonize private support and private care. We don't see it as supportive adjunct to the healthcare system, because we know in particular disciplines, cardiology, neurology, oncology, the system works very well. Yes, albeit I know COVID has impacted waiting times, but the problem is, to then Rhona's point, it's created expectations. So, and it's created the wrong aspect of expectations. So a lot of people, when they come to me, they're very surprised that, for instance, they have a first hour, an hour 45, and some clients have had 2 hours just as an initial consultation, because they just want me to deal with the symptom. But the system has always been set up, well, this is a symptom. I don't care about the cause, because all I want that patient to be done is feel happy so I can discharge them. There's a lot of patients that I actually refer back to the system, and I don't see them, and I'm losing probably potential money and income because of the value system that I've created the clinic on. Because a lot of people don't forget, they forget, even for gastroenterology more particularly so, is that each patient, once they're diagnosed, they have a set budget. And it's so harrowing to hear when people say, well, I'm having issues with my food, can you help me? And I always say to them, well, first, if you've been diagnosed, did you see a gastro-dietitian in the NHS system? And they'll say, I didn't even knew one existed. So I say, well, please speak to your doctor first, because your budget should allow that. And if not, then come to me. Then that kind of reduces that barrier, because to your point, a lot of patients do get shocked and they say, well, why are you talking to me? Why are you asking me sleep? Why are you asking me about stress? Why are you asking me about what voice do I sometimes use and talk around? A lot of my work, I spend more time, and you've seen it, sometimes it's just asking, well, how are you? And then understanding the nuance of tone and the verbiage that a potential client uses, because that's more powerful than saying straight away, they'll say, well, this hurts, or I've got this issue. And I would say to them, leave that for after. I just want to know, how are you today? What has happened to you today? Because once you tap into a patient, and you tap in, the way that I work is I work emotional, mental, physical, and spiritual. You start seeing the embodiment of a person. And you can tell, Rhona's consultations, sometimes we'd have them when you were in the car or walking.
Classic.
Sometimes
he knows this about me, Payman.
Sometimes, but I want to be part of that patient's life. If I see it in this kind of sterile environment where, Rhona's sitting in her lounge and she's relaxed, that's not going to show me the actual state that she actually exists in. And that's when we start hearing the saboteurs come through. And I think that's important.
I think there's, the what do they call it? The gut-brain axis, right?
I've got questions about this too, so Yalla.
It's well established, right?
Yes.
Nowadays. So what percentage do you think, I know it's a difficult question, but what percentage of gut health is stress influenced? Would you say 100%?
I can tell you anecdotally from my practice, and I'll tell you what some of the data shows. Yeah. Okay, so if we look at IBS as an analog, okay, so between 1 in 5 and 1 in 10 people have IBS. Okay,
really?
Yes. 30% of those will have a depressive or anxiety or panic-led foundation that has led to the condition. Okay.
And just to clear it up, IBS, irritable bowel syndrome,
yes.
Not inflammatory.
Not inflammatory. Yeah. And that's where sometimes it is convoluted. Yeah. Inflammatory is the far more severe spectrum, which we know is an autoimmune driven. Yeah. IBS is irritable, and we tend to find actually the vagus nerve, so when you're talking about the gut-brain axis is linked in a number of ways. The way that I always try and explain the gut-brain axis is just think of it as a bidirectional communicative system, because the gut in itself is a system, an ecosystem on its own. It has its own nervous system. It works very very independently to the central nervous system. But it's linked also physically with the vagus nerve. So we tend to find, and we've seen with data with patients and large data cohorts of patients with IBS that have gone through vagus nerve dampening exercise, the simplest thing like yoga or breath work, their symptoms resolve or reduce, and they get to the point where they can say, I'm in remission. So anecdotally, I can say to you from my clinical practice and the hundreds of clients that I've seen, that I would say a good 80% of my clients are all from a stress kind of gut-brain axis-led IBS or gut health issue. The data says 30%, but you have to remember a lot of people are lost in the system, and they won't probably have CBT or gut-directed hypnotherapy or
it depends how you measure it, doesn't it?
Well, exactly.
If the measure of it is you've gone and seen a therapist, psychotherapist, then that's a certain percentage. But you might not have gone and seen a psychotherapist but still be stressed.
Exactly. And in the medical system, depression it's analysed or kind of diagnosed through the symptoms, and if you've been given an SSRI or SNRI or a TCA.
Right.
And then we also know, if you look at just antidepressant medication usage, 30% don't respond.
To antidepressants?
Yes. So that already tells you in terms of, because people aren't looking at, actually, are there other aspects? Because we keep thinking serotonin, and you'll hear this in everything around gut health. Everyone keeps harking on about serotonin. 95% of the serotonin is made in the gut, but it doesn't go to the brain.
It's so interesting because actually...
I didn't know that.
No,
there was a dentist. This is why it's really important. You told me that. Daniel Murray told me that. I wrote it in a post, and there was a dentist, one of our faves, one of the trolls, the older trolls, started telling me that there was absolute BS about the serotonin in the gut, and I was like, no, it's not. Like, you know what I mean? And like, that's the thing, because people just don't know, and it's so important.
And you'll see a lot of health influencers now talking about gut health is booming in terms of the research behind it, and it is this almost holy grail of health. So everyone's saying, if you optimize your gut health, your mood and mental health will be fantastic because it's upregulating serotonin. But actually serotonin, the reason why the gut makes serotonin and why 95% of it is in the gut is because actually serotonin supports gut transit and motility. The 5% that you need in the brain is just one aspect of mental well-being. There are other neurotransmitters that are far important. What we don't hear about in the gut is GABA, the butyric acid, things that, the dopamine. That's going to have a much more positive impact, but actually it's the physical, it's the vagus nerve. The vagus nerve is the largest of the cranial nerves. It innervates so many tissues and organs than we realize, and it's a great link because it actually innervates a lot of the face, and we know this is where there's potential link with dental, with gut, but it's really understanding what are we treating. Are we treating the symptom or the cause? Because the cause, we know with antidepressants, is they'll say, it's because there's not enough serotonin being produced, or serotonin uptake and it's not that. It may be other things, because the blood-brain barrier means that you may have the 5% serotonin, but you may have a SERT gene or a transporter gene issue, or there's a receptor uptake issue where we actually just need to reset and kind of make people just ground back and take an understanding of actually let's upregulate kind of in a harmonious way. Sounds very spiritual, but it does work scientifically as well.
I think it's important that you have that sort of holistic view on it, because in the medical sense, we're always looking for something not being enough of it, and so we need to give more of that. But the body, you take a simple blood test and you realize too much or too little of something,
it's not good for you.
Can be a problem,
exactly.
Right?
So the thing is, I'm going to be a bit controversial.
Of course you are, because you're a doctor.
So there was one thing that you and I slightly disagreed on, and I'm going to challenge you on it, because I think that there's more and more research now to show that it has benefits, and that's fasting. So if you remember, we'd spent a lot of time building up my gut. So just to give you an idea, we did a program together. So it meant taking lots of different, so like for example, like having a kiwi with the skin and chia to kind of get my like bowels moving, and then glutamine to kind of like help the lining. And there was all these different elements that like he had provided holistic care. then shock horror, I said to him, Sunny, by the way, I do a fasting clinic once a year. And this fasting clinic, it's run by doctors, dentists, doctors, nutritionists, psychotherapists. It's very holistic. It's very medically run. It's been around for about 100 years or 150 years. It's a family-based place. And the fasting is tackled from 2 points. So one point is the spiritual fasting. And as you know, even like in all of our own like cultures and religions, fasting has always been used as a spiritual way to connect, which I massively believe in. And then there was the fasting for your body as well. So like the type of people that go to this retreat are about 50 to 60 years old. A lot of them come with type 2 diabetes on metformin and leave not having to use their metformin. And they also have clinical studies for long COVID. So the reason why I went is because I had COVID and they had said that there was benefits. Now, I love it, but obviously Sunny was like, I'm not sure. And, there was a little bit of like going back and forth. Interestingly, Ella, who, as you know, has been on this show, Ella said to me that there's also studies to show that the brain, there are like releases happy hormones. This is interesting, releases happy hormones when you're binging, but also when you're starving. Right, as in like fasting can actually make you feel happier. I mean, obviously, like there's a balance.
Prav always talks about it.
Yes, correct.
But I think I think it's difficult to say. We're going to ask you in a minute.
Yeah.
It's difficult to say, is fasting good for you or not?
No, I'm not asking that. I'm not asking that. But I'm saying I'm not asking that at all. But I'm saying that I have noticed the benefits of fasting, and as you know, on Stephen Bartlett's, he's had a lot of fasting advocates. I've noticed the benefits of fasting, and even for me now, I do some intermittent, and I'm an advocate of it. But do you think that is it recommended for people? If it is recommended, how can you do it safely? And what's your thoughts?
Okay, so this is the biggest mootest point that you're going to ask me. We as a society have confused fasting, intermittent fasting, and time restricted eating. Okay. Now, we've gone from, this goes back to your point, Payam, of one opposite spectrum to the other. Now, if we look at positive dietary habits, and we've seen long-term data in people with diabetes, for instance, we know that time-restricted eating, which is essentially narrowing the amount of time that you actually eat in a day. So you may have a later breakfast and an earlier dinner, and they advocate eating around about 10 a.m. and having your last meal at 5 p.m. You're already doing essentially what we call intermittent fasting. What is intermittent fasting? You're just, again, narrowing the window and you're reducing your calorie intake. The issue where fasting has taken, or there's been this accelerated growth and kind of media frenzy around it, is because it's linked with things like weight loss. But all we're doing is we're restricting calories, and it's actually creating restricted and disordered eating behaviors, which I see a lot in my practice. Orthorexia is on the high. Orthorexia is not a clinically diagnosed aspect or diagnosis.
Orthorexia is?
Yeah, so it's not a diagnosis.
Explain it.
So orthorexia is this fascination, obsession with clean living, healthy eating, and essentially being, or telling yourself or lulling yourself into this concept that I'm being ultimately the best I possibly can be. But it does create unhealthy patterns of behaviors, thoughts, and actions. So it could be restricted eating, not eating at all, and it generates body dysmorphia. So where I have my quandary and my issue with fasting is the prolonged fasting state. So yes, we know biochemically it creates or enhances autophagy, which is the enhancing and cleaning of dead cells. But also, by the way, a Mediterranean diet can also support a very good...
Big up, Lebos.
Yes,
go on.
A very good antioxidant-rich diet and reduce the amount of inflammation. My worry is, and you'll see, and the issue is we don't have long-term data. And I know as clinicians, we're always thinking that the gold standard is randomized RCTs. And life isn't about RCTs, I know that. But I can also tell you that we just know from data that comes out, and you can see analogs, calorie counting, reducing calorie intakes, the people that rebound with weight gain, and actually the mental health knock-on effect it has down the line is far more adverse than others. Now, Rhona, you're different because you know your body, but a lot of people don't, because they go to these clinics or to practitioners, and I'm saying practitioners, with the hope of a cure, because they're sold, I will cure you of diabetes. Now, you may no longer be on metformin, but you're still a person with diabetes. You just don't have medication. I still have Crohn's and colitis, even though I'm in remission, but I still have Crohn's and colitis. I'm not cured even through my system. And that's where my quandary lies with it all. I'm an intermittent faster, but I don't say I'm an intermittent faster because my natural body and hunger cycle is built around the fact that I don't like breakfast in the morning.
Same.
I eat at 2 p.m. and my last meal is around about 6, 7, but that also helps my gut, and I'm in remission from that. But I don't go around advocating, like a lot of influencers and sometimes practitioners, just saying, oh, intermittent fasting cured me and saved me. And that's where my issue lies.
I think I totally, and I think that's why on purpose I chose a medical. Like, you know, this place is not the sort of place you're going to find influencers in bikinis. There's literally like 80-year-olds walking around.
Tell us about it. Is it 3 days?
No, 10.
10 days of not eating.
This is where my quandary lies.
So basically, let me tell you what happens. You get to the clinic, right, and it feels like a hospital. Like, it really feels like a hospital. So you get to the clinic, and as soon as you're there, they like... The first morning that you're there, you go and have your blood tests, you give your urine sample, you have your appointment with the doctor and your appointment with the nurse. And on the first day, what they do is they do what they call like, they do the day where they sort of like reduce your calories but don't take you off. So they put you on 800 calories, but it's a very fibrous meal, right? So I think it's to kind of like make sure everything's moving. So that's day 1. And then on day 2, what you do is they do what they call like a liquid day. So they give you like salts to clean out like everything out. And then what you do is that you are actually given like a clear broth and a sort of like half a juice essentially. And basically you continue that. So you have a soup and a juice every single day for 7 days, okay? Every single day you are having your blood pressure checked, you're having your weight checked, you're having everything checked. And they don't allow you to do it if you're underweight, by the way. You see the doctor like twice a week within that week, and the nurse every single day. The facility also has, as I said, osteopaths, physiotherapists, nutritionists, etc. Then on day 7, you break the fast, and what they do is they give you an apple and some nuts and then like a soup. And then for the next 3 days, they introduce all the different food groups. So by the time you leave, you're on about 1,200 calories. So it's not like you go into binge phase straight away. I know he's like, I'm not happy about it.
I have so many things I would say here.
And to be honest,
how do you feel as you go through
so
it? Do you feel
as
better?
you feel, so it's really interesting because for me as well, again, the environment is set up for this, right? Because you've got meditation, you've got yoga, you've got group therapy, you know what I mean? So you've got all of these different things, and personal trainers, tennis, you know, all that sort of thing. So it means that you are not stressed, and you know, they make you do a liver pack and things like that. So for me, it was the right environment to do it in. And to be honest, the results, I sustained it because I do it once a year. I took my partner with me for the first time, and he's Greek, by the way, so telling Greeks you have to pay not to eat was like a challenge in itself. But he loved it, and now he's the best he's ever felt. And what he does is that he actually now fasts 1 day a week completely for 24 hours. He just has a green juice. I actually can't do that. Now, what I've realized is, and again, it's about being intuitive. Before I met you, I used to shame myself so much for eating like chocolate, as in like it had to be. Now, I literally, like I just had a bite now. I know, fine, it's a protein bar, but as in like, I literally don't care, because what I found is that like my weight and my mental health is the best it's ever been when I allow myself a treat every day. Because we've discussed, I have a sweet tooth, so I'm not going to deprive myself. And as long as I'm not having the entire cake at once, I don't care that I'm having a bit every day. So I think that that's really important. But as I said to you, like I had such clarity because it's my favorite time to journal when I'm fasting. So I can write pages and pages of like streams of consciousness. It's really weird. And you're really alert. Like I feel my sharpest, you know, when I'm there. So for me, it's not just about weight loss.
I think it's for you, it's the environment.
Yes.
It's escapism.
It is
because I remember when
escapism.
you came back, you're already anticipating. You're like, my symptoms will come back. I know they'll come back.
Yeah.
The issue where it lies is just, I think for you, you are a rational human being.
Yeah.
A lot of people will go with
Jury's
misguided.
Jury's out.
And it's because it's your podcast. I have to be less controversial, but that's another podcast.
That's the most controversial thing I've ever heard.
My issues lie in just also how you've just described that. Okay, so as a human being, you need as a minimum 1,200 calories for organ function alone. Now, the other thing is, and we've seen this, and a lot of your listeners are going to know that regardless of what qualifications you have, and we've seen a lot of MDs in the social media space advocating the worst diets on the planet and saying, seed oils are bad, no longer use an air fryer, free plastics, etc., etc., etc. And it's misguided information. And I think you can always find a community that rallies around what you believe is true science.
It's called an echo chamber. Do you know about this?
No, I don't.
I wrote about it today. I said the most dangerous thing about social media is that we're all living in echo chambers. So due to the algorithm and due to the way everything's up, we just have people reinforcing our own beliefs, thinking it's the truth. But it's actually very dangerous because we're not inviting diversity or considering different points of view.
Do you not follow accounts that you don't agree with?
I do.
But
the thing is because I recently, with what's going on in the world in the last I've had death threats in the last couple of weeks because people believe so strongly about the opposite side, and we're not going to get into that, about the conflict, that they're annoyed with me for not advocating their side. They're angry with me, and I'm like, because we're living in this dangerous zone right now where people just are in echo chambers, and I'm like, no, hang on, I look beyond social media, by the way, for my information for that reason. So yes, go on.
And that's the thing. And I think because of that, we can create our own collectives.
Yes.
And then we create our own siloed echo chambers. And it just, for you, I felt the reasons very different for going to that clinic, because actually if you talk about the positive gains that you got from it, you were talking about more about actually being in tune with your soul, your creativity, your brain. We know with your kind of practice and how busy you are, you sometimes need to just take a step away from it. But a lot of people, it's when they go and say, well, actually I'm on 800 calories and it's brilliant for me, and we're like, well, what is this based on? And actually, it's like the salt solutions. Well, actually your liver and your kidney do natural detoxing. It's things like that. So when I think, what are the claims being made?
Rhona,
always do what you want to do.
You said it's not just about weight loss. Is it about weight loss at all?
So I think the thing is, as Sunny said, Payman's really mean to me, by the way, but we're not going to go into that. I've always suffered with body dysmorphia, where I think I'm a lot bigger than I actually am, and then there's sometimes really mean people that affirm it, but we won't go into that. But the point is that I used to have, in hindsight now that I know I had an eating disorder at university, but again it was orthorexia, because I was like, I'm just really healthy and I can just be vegan all day and eat 800 calories, and I used to be like, that's fine, and I was so skeletal, people, I'd walk into a room and everyone would be like, oh my god, she looks so unwell. It was probably around the time that you first met me, and then I basically just had masked that. So I think that if you've ever gone through any kind of restricted eating, you will never fully be like, oh, I don't care about weight loss. I'm not going to be someone that's going to put on 20 kilos and be like, I'm happy. Because there's so much. And I think when society affirms that you look better at your smallest, skinniest self, it's a really hard thing. And I try to break that toxic narrative. And also, in answer to your other question, I follow accounts on purpose where there are beautiful women that aren't stick skinny and embracing it, because their messages then start to infiltrate. And I know subconsciously when I see that, I'm like, it's great. If you're 2 to 3 kilos heavier at this point, it's okay. Your cycle, your stress, I'm cool. But am I going to be okay with 20 kilos extra? No. And I also think we've gone too far. We shouldn't be celebrating obesity. I'm not fat phobic, right? And I understand that some people are the size that they are for very multifactorial reasons, but we also know that obesity is heavily linked to diabetes, heart disease, and other things. So I'm not going to be that person that's like, you know what, if you are 200 kilos, everything's okay. I just think it's the reality.
So look, I agree with you here. So just to give you my perspective, this is also why I did my clinic. So I am recovering from an eating disorder. I had bulimia for years, from the age of 13, and I would still say I have the eating disorder. I was in relapse this year. I was in remission for a very long time. And what it's shown me is, as humans, we have built, how you're talking about the fasting, the overeating gives that dopamine hit? Well, this is how eating disorders exist. I would get my dopamine hit by my restriction and my purging. It gave me a sense of control. When, as humans, if we look at society, where do we find our measures of success and control? What we do as a job, the amount of money we earn, the food that we eat, and how we live. And food for me has always been, I've come from extreme poverty, so I've never really looked at, okay, I must have, a 6-bedroom house and I know I've hit it. For me, my early control memories came from food. To the point that, I came from a family where we lived in a joint family. We had and it's so trite, but KFC once a year between 2 families. So you can understand actually, and if we look at healthcare professionals, a lot of them come from kind of humble upbringings, migrant families where food is so central. And it doesn't surprise me, a lot of the people that I see have underpinnings of disordered eating and potentially an eating disorder, and they use that as their form of control. Now, what you've said around about, okay, yes, having that balance in terms of, knowing people that are body positive and body negative, and I do agree, I think, we've gone just too far, way too far, because if we look at the data and the epidemiology data, 1 in 5 children are obese now. If we look at, in America, they're saying, 50 to 75% people are considered overweight. We live in a society now where we feel overweight is normal. And this is why we have a burden on the healthcare system. Where we need to kind of find the balance is, and I see, I've had clients that have been 200 kilos, by the way, and we've worked on medically assisted programs with weight loss injections and the behavioral coaching and dietary intervention to get them to 100 kilos, 95 kilos. But they have gone on an empowerment journey. But there's a point where also these people start having restrictive and disordered thinking. I have some clients that will say, I now weigh myself every day because I've put on a kilo. I'm like, we're going to stop now, and I'm going to take those weight loss injections from you, and I have to use it as a control, as a power play, because the psyche kicks in. So it's where are we getting this balance? We're almost rewarding kids for eating and embracing food, but not being as active as they used to be, and then we worry that they are obese. But then as adults, we're saying, well, we should be body positive, but we're not actually understanding the health aspects and the considerations, because as you say, it's not even just as simple as the diabetes. These people are just not active. They have COPD, they have breathing and asthma difficulties, and their quality of life isn't as great as what it could potentially be. But I always say to people, don't look at your ideal weight, look at your healthy weight. So even for that 200 kg patient I had, I wouldn't say to him, well, for your height, you should be 80 kilos. We'll say, actually, your healthy weight is going to be 100 kilos. Then we'll see what healthy looks like for you, because you need to go on a behavior change journey first and almost reintroduce yourself to your body. So there's a lot there probably to unpack. And I think for me, the reason why I get so passionate about this is because I know what an eating disorder's like, and I know what the signs are. And I kept it hidden under the system. I mean, the reason why I talk about it now is because, my family never knew that I had an eating disorder. Mothers always know. They always say, well, why are you always going to brush your teeth? You just think, well, we live in a vain society. Let's just constantly brush one's teeth. And the restriction was just, I used my health condition as a great kind of Trojan horse. I can't eat because it triggers, Everybody knows when you've got an eating disorder. It's when you don't know you have an eating disorder. So I'm in the process of actually writing a book about men with eating disorders.
Yeah, I was going to say, because I think for men as well, I mean, maybe Payman, you can comment as well. Like, with women, we sort of, again, this is like the awful thing, right? With women, we're like, well, she has an eating disorder. We say that like it's okay because everyone wants to look like a model, especially if you were like a 90s, 2000s girl like I did. Like, it's kind of like, oh yeah, she just doesn't eat. She just doesn't eat. Like it's normal. Again, we've normalized not eating. But for men, I learned that so many men also suffer with like body dysmorphia and eating disorders. How common is it in men?
So the data is very limited for men. But if you look at anorexia nervosa alone, it's said that of people that have anorexia, 25% are men. The issue we have is how many men have bulimia or ARFID or other disorders. We don't know, because men come to the system very, very late, and unfortunately they get complications late. And actually, eating disorder related deaths are higher in men than women, because women are referred into the system earlier, and the system is set for women, the information, the bedside manner, the therapy, the protocols. It's not just as simple as a man is going on and has an eating disorder because he has body dysmorphia. There is so many other things. There's trauma, sexuality, other intersections, socioeconomic status. If you have had an unhealthy relationship around food as a child, if you did come from poverty, you may actually idolize food in such a point of time where if you don't feel good, if you have depression, you may think you're not worthy of food. But as men, we don't talk about it. And I know if you look at data for homosexual men, gay men, it's more prolific. But again, it's because we've normalized it. Yeah. So for women, it's the Sex and the City era. Yes, we don't eat. Ladies at lunch, it's liquid lunches. Yeah. For gay men, it's so obvious why he has an eating disorder because he wants to either follow that twink or femme kind of ideal or tribe. But it's not that anymore as a society. And you've brought up actually important kind of a red thread to all this. It's labels, but we label the opposite spectrums because it's what we know. The middle is such a grey area. We fear the unknown. So as a society, I can't say to someone, by the way, as a gay Indian man, I have an eating disorder and a chronic health illness because I came from poverty and I suffered from white privilege in the workplace. Yeah. But it's far better for me to say, as a gay man, I have an eating disorder. Because they're like, it makes sense because you're gay. Because you feel you're going to be more attractive. Same goes, you're a woman, you don't eat. And in society, and we all come from actually these type of cultural communities where we almost idolize thin people as well.
Totally.
It's like, you look so wonderful, you've lost weight. But the minute you put on weight, you look a bit too healthy. In Indian culture, that they've kind of taken a word and they've almost bastardized that word to the point where you think, well, is healthy good or healthy bad?
Oh my gosh,
anymore?
It totally resonates. And this is the problem, right? Because genuinely, like when I go to the fasting clinic, it's all about the way I feel, my hair, my skin and stuff like that. And then naturally, obviously, like for me, I'm never going to be someone, because some people go to the fasting clinic and they can lose like 7 kilos in 10 days. A lot of it's water weight. I'm that sort of 3 or 4 kilo person, which is obviously like because there's not that much. But the amount of praise that I get for how amazing I look after it, and then it makes me feel that if I put on 3 kilos, I'm not worthy. And then, like you said, if someone takes a photo of me and I don't like it, and I'm like, I don't like it. And she's like, no, you look so healthy. I'm like, I look fat. I need to immediately go on a diet. Do you know what I mean? And like, it's so crazy how the word healthy has become really negative. Like people think, whereas skinny is you look good.
Yes.
It's
the reward system we've been created by society, the verbiage we use, and our own internal systems, because it's probably likely your saboteurs are going to be hyper-vigilant, and so you're always constantly on this vigilant perspective where, what does healthy mean to me? If someone said healthy, do they mean I've put on a bit of weight? Or do they mean healthy as in I look in my prime? So we're second-guessing ourselves. The issue with society has made us think health is associated with weight, not, are you sleeping well? Are you more active? Are you kind of within, in your environment? Are you actively engaged? Are you kind of living with your family in the most kind of beautiful way? Are you spiritually active? No, healthy is, do you look a healthy weight that society has made me think
it's not
I
healthy.
should look? Yeah.
I mean, Sunny, I'm very interested, because so much of the stuff you talk about is where stigma attached. The gut itself, for some reason, we don't talk about it as much as if you had a shoulder injury. The Asian part of it, the gay part of it. You don't strike me as someone who really cares what people think about them. And yet, I mean, you wouldn't be that person if you're out there shouting about all this stuff. Yeah. And yet, now that you're talking to me, I feel like you really care what people think about you and worried about it. And so how do you manage that?
So the answer to your latter is because I'm human. And I'm a construct of a second generation migrant family. My father migrated a lot later than the early Indians did. He came in the 80s. So I am a product of societal expectations, and I come from a very strong patriarchal family. And when I say patriarchal, I don't mean the Western misogynistic construct of patriarchy. I mean what we're all probably used to with patriarchy. It's that grounded earth, masculinity is celebrated in
positive masculinity.
Positive, not the toxicity. So there was an expectation. So that expectation just weighed me down constantly. It's taken me a while. I only came out 2 years ago. I've only started talking about my eating disorder, possibly because a book deal came my way. As materialistic as that sounds, yes, I'd written articles about my eating disorder, so somebody found me, but it's once I found my true self. Now, it's interesting that it's the perception versus what my saboteur is inside. My saboteur is very much a victim and a judge. So I've built a lot of masks. And the timing of this podcast is brilliant, because if you'd asked me a year ago, I would not be openly talking about homosexuality, the taboos, the stigmas. I would happily talk to you about gut health stigma, because as a British and Western society, we don't want to talk about bowel habits. We don't want to talk about blood in stools. And we don't want to talk about vomiting, but we'd rather talk about something like a shoulder pain, because most shoulder pains or muscular pains are associated with, I was doing something active. Whereas a gut health issue is, I have something wrong with me.
Yeah, so
and
true.
the issue is, we think it's going to be the big C. When it happened to me, I, for a good 4 years, allowed blood in my stools. I didn't tell anyone until the point I lost 6 kilograms in around about 2 months. And for a man in his 20s, you should not be losing 6 kilograms in two months. And I knew, and I said to the nurse, I think I've got cancer. What else could it be? What else? And she said, okay, we'll get it checked out. And I just kept it so quiet. And I resent it now. And this is why I'm so vocal about it, because there's so many people out there that probably do have blood in their stools, or they think, am I gay? Am I bi? Am I pansexual? Am I this? And I'm just thinking, like, we as a society have built ourselves around this safety structure of stigmatization, thinking it actually builds character. And it's only when I started writing the book that I was thinking, oh my God, the trauma that I've had to dissociate from. And you just wonder how many people are dissociated from so many other things. And that's why I'm more vocal. But yes, there's the saboteur in me right now talking while I'm looking at you, saying, you've really dug yourself into a hole now saying all this. You've really effed yourself. But but that's the saboteur, because the saboteur is that pristine Indian boy, the golden boy that everybody looked up to. My grandparents, the doctor. Every time I go back to the village in India, they're like, oh my God, Dr. Sunni's here. He's so good. And this is the thing, good looking. I know I have passing privilege, but I'm also a subject of other privileges that have been discriminatory against me.
That's how I feel too.
And this is my biggest thing, and this is why I get vocal. People look at us, right, and they think, well, educated, good-looking, well-clothed, well-spoken, but actually 90% of it, yes,
dying.
90% of it is a mask.
This is the he always gives me. He's like, "Why are you so broken?" I'm like,
because
why?
That's how we survive.
Yeah, literally, how we survive. There's one really important thing that I want to ask you as well. We have to have you on for a second time, because I find all of this so fascinating.
We didn't even speak about the gut microbiome.
That I do want to cover that, but listen. This is something I'm going to ask you selfishly, and I'm sure a lot of people can resonate. When people say it's a gut feeling, or I felt it in my gut. I set out on this mission a few years ago, and I really want to start listening to my gut. But I never know, and I still don't know. And this is the thing that's crippling me. How do I know that it's not my gut, that it's my gut and not my anxiety? Because for me, I'm like, is that my anxiety speaking to me, or is that my gut, or are both of them the same? I'm still not in tune with it. And sometimes I make decisions thinking it's my gut, but I'm acting out of anxiety and fear. I'm not acting. But then sometimes I'm like, what's this feeling? Should I be listening? So I'm finding it so confusing.
As in gut instinct.
Yes, exactly. Because sometimes I think it's a gut instinct, but then I realize it's anxiety. And sometimes I think this is a feeling I shouldn't feel. So should I be doing something? And I'm ignoring it. And I set out on this mission literally about 6 years ago.
Your anxiety is so overarching, though. Sometimes I send you a text saying, call me. And you call me and go, what's wrong? What's wrong?
Yeah, I know.
Yeah, because she's always in fight or flight.
There's nothing wrong.
She's constantly in fight or flight.
But let's go into that feeling, because when you feel it in your gut, is it gut or anxiety? How can you tell the difference, and what do you do?
I'm going to answer your scenario very simply. If you're overthinking, if it's gut feeling, it's anxiety.
Okay.
Because gut feeling or instinct is something that is you just know.
Yeah.
You just know.
But when people say, sorry, I'm going to interrupt you there because there's another thing. When people say also, you know when you know, for example, when they're in love, right? And I've been in this situation
That's
before.
BS.
I think that's BS because...
That is BS.
I think that's BS because I'm like, you've known this person for 5 minutes and I've been there. But also because I have trauma bonds, I fall in love with... I have historically, thank God now I'm in a healthy, amazing relationship, but which took work as in like to find that. I always thought that love meant... I always felt in loved when I was in a trauma bond, essentially, because I felt like I know when I feel it in my stomach, but I was like, okay, is this, now I have to be like, is it a trauma bond? But I find it very triggering when people say, you know when they kind of meet someone after 3 seconds and they're like, I'm in love. You know what I mean?
What's a trauma bond?
Do you want to explain something?
So I'm going to unpack this because this is really,
yeah,
really
this
deep.
is so
what you're
interesting. That's why I
talking
wanted to go
about.
into it.
I don't believe in love. I mean, you can put that out there. I do not believe in love. The reason why I don't believe in love is because love is a construct of an attachment. What we believe as a modern society is that I love someone, but what you're doing is actually you've built an attachment to them. Love actually comes from within. This is where I put in the spiritual side of what I do. By self-loving yourself, you're actually self-accepting yourself. And actually by building that bond and attachment with someone, you're saying, I attach with you and I accept and I validate that you exist in my space. Love is such a loaded and sometimes a negative psychological connotation, which is why trauma bonds exist and why we sometimes overuse the word love. There's a study, and I read it somewhere, that men are the ones that will use love far quicker than women.
Really?
Far quicker. Usually around, on average, 3 months into a relationship.
Yeah.
The reason why...
You agree?
Men fall in love at a drop of
because
a hat.
of trauma bonds. Because of trauma bonds.
I'm not sure.
The reason why it's the trauma bond is trauma comes in a number of different forms. Trauma can also be, as a child, my parents never gave me unconditional love. It was always based on conditions. I accept you, I love you, and parental love, especially in ethnic minorities, are sometimes...
On achievements, as we all know, on
yes,
achievements.
It's basically, I love you, I'm saying I love you, but actually I accept you and you're validating what I'm living through vicariously through you is that you've got the degrees and the things that I need. Men have different types of trauma bonds to women, and I'm generalizing, but sometimes a male can also say, well, as a child, nobody said that I was accepted or loved. That creates a trauma within your neurobiological and psychological system.
Yeah, but why isn't that, like, if you're finding someone to fill that trauma,
Well,
why isn't that love?
That's a trauma bond, because what you're doing is you're using someone to fill that trauma, as opposed to saying, I'm authentically building a connection with you, because what you're actually doing is you're filling the void and saying, I just want that someone, I want to feel like I'm loving someone.
You want familiarity.
It's a transactional
so
relationship.
for example, I'm going to give you in the celebrity world.
I
No.
get it.
No, but like, so Johnny
Go
Depp
ahead.
and what's her face, the massive law case. Not Amber, what's her name, Amber?
Amber,
whatever.
Yeah.
So basically, Johnny Depp and her are the perfect example, super toxic and super fiery. And again, people associate that fire, that feistiness with love, right? Because they think it's passion. But essentially, she came from a broken background, he came from a broken background. They were two broken people wanting to be fixed, okay? And essentially, what they're doing is they're fueling each other's traumas, and they mistake that for love. Sometimes people also mistake safety for boring. And what I realised through my work, that feeling safe is not boring, but we've associated because it's not familiar.
Different people have different
No,
outlooks.
you're making
no, they do.
Payman needs
Okay,
therapy, I know.
Payman, it's not that different people
Have you ever been in love?
Yes.
I've falsely been in love, but what you're confusing and how Rhona's explaining it is a lot of people confuse lust with love. So they think I've built this attachment because I'm vulnerable and I connect with them because I came from a broken home and this person understands me because they came from a broken home. I love them. And actually what you're doing is I lust because they're filling validating
I get
the
it.
victim.
I get it. But and we need to sort of separate, familial love with romantic love, and also falling in love with loving someone. Falling in love is not a permanent, it's a temporary
state.
It's a temporary state.
I would argue with that.
Years.
I think if you find, from a romantic perspective, if I tell you as a human person, from a romantic perspective, you ask me, have I ever loved?
Yeah.
I think I have loved, but not in the true context of what I should be able to love. If I find someone that I can attach to extremely well, I should be able to fall in love with them constantly.
Forever.
Yeah, exactly. And also, if I look at it from a
No,
spiritual
look at my
understanding,
parents. Look at my parents.
In love.
Yeah,
In love.
My love, in love.
Look, in love.
In
yeah.
love, in love.
I
My
think it's
parents-
possible.
But
I
listen,
think
but
it
do you know
is.
what it took? They went through massive states, but like you said, and it was really interesting. I had this conversation with my partner. It's about constantly being on that level of wanting to like challenge each other. It's on being on that level of like wanting to do things, because like the lust goes after the honeymoon period, because obviously you see that person, that whole like I want to rip your clothes off sort of feeling. Of course it does. But it's about falling in love in a different way, and you can fall in love. I'm not saying love as in like, oh, I love this person, but you can, because you can challenge each other, you can grow together, you can you can adapt to one another.
Of course,
And
but the falling piece is the uncontrollable,
no,
illogical.
I think in my safe loves, if I, having chosen a partner that is so open to change, compromise, feedback, etc., the response to my traumas and stuff makes me feel I fall in love with you over again when you understand me in that way. It's not that ripping the clothes off feeling, which I think is what you're talking
I'm not referring
about.
to the physical. I'm referring to the
reason why I think
the illogicalness of someone who's in love.
There is a logical element to it, though. So the romantic side of you saying it's illogical, but the rational side, your consciousness would actually say, well, actually, as a person, irrespective if you're with someone or not, as a person, do you agree from childhood to adolescence, teenager to adult to senility, you learn and grow with experience? Sure. Yes? So surely, if you then add someone else into that equation, you're both growing and learning together and separately. So sure, you do have to fall in love with each other, because there's different aspects and milestones of your life and your subconscious and your consciousness that you're always going to evolve and grow. And I would want someone to fall in love with me the minute that I'm on my deathbed and actually see, I see a different type of Sunni, and I'm in love with you still. Because as a Hindu, I also believe that I will find that soulmate and that they will continue in 7 afterlives. Unfortunately, lust has made me believe I was in love and I found that soulmate.
Yes.
But actually what happened was I didn't love myself, and I didn't love myself to the point where I need to realize that we evolve. Now, going back to the original question about gut feeling, I've tapped into, and the way that I work with my clients is all that spiritual element. I will tell people, you will know instinctively if something is true instinct is when your brain, your heart, and your gut align. Don't always look at just one part. Oh, my brain is saying this. And the medical aspect, we would say, was, are you using your subconscious or your conscious to rationalize it? You are using your subconscious through anxiety. Conscious side would say, well, actually, these are the facts, and this is what I'm going to do with it. The gut feeling, you've got to put aside symptoms. You will know, and I know it's a really, it's a weird way of explaining it, but you just know. If you're not questioning it, that is your instinct. If you are questioning it, your consciousness has kicked in because your subconsciousness has overpowered your thoughts, and it is probably anxiety. And that's where you need to then work with people to actually understand, how do I differentiate my conscious and my and that it does start coming in with experience.
Maybe I need to come back to you with this second part, the emotional gut.
We need to discuss nutrition.
Yeah, of course. I'm so sorry. Like literally, it's just been fascinating.
But Sunni, so we've gone sort of holistic. We've talked about stress and sleep and all of that. But let's just talk about nutrition for a second. Right? Number one, what percentage of diets are ideal? What percentage of people's diets are missing something? And number two, can you unpack the whole probiotic prebiotic piece for me?
So those are very heavy questions. Okay, so you can always cut data to make any dietary pattern look good. Okay, you could have a paleo, you could have a plant-based person, a vegan, keto, carnivore, and they're all going to say, I have lost weight, I sleep better, I perform better. What have they essentially done? They've cut out processed foods, or kind of ultra-processed foods. And actually, by harmonizing and balancing your dietary patterns, you're going to see positive gains. Now, the data is very conclusive and strong around the Mediterranean diet. Okay, so if we look at also linking it with mental health, right, there was a large longitudinal study, SMILES data, which is quite apt.
SMILES, love it.
I don't know, that actually showed the Mediterranean diet had a positive impact on reducing depressive states and symptoms on depressive scores and questionnaires. So I would generally say to people, and this is how I guide people in terms of my practice, is think about the holy trinity of meals. What are the typical macros? Think of a good lean protein, complex carbohydrates, and just shitloads of vegetables, lots and lots of vegetables, just antioxidant rich. That's when you're going to get the omegas, the vitamin D, the calcium. We've overcomplicated nutrition
in healthy people.
In healthy people,
because I know in irritable bowel or not in inflammatory bowel conditions, they often say don't have vegetables and so.
Well, okay, so now so if we go on a grand population level, that's what we know that dietary patterns should be, and that's validated through all healthcare systems. Yeah. But when you go to individualistic inflammatory bowel disorders, other autoimmune conditions, people have different triggers. And that's when you do have to have a personalized approach. My triggers are very different to someone else with Crohn's. For instance, in theory, you should be able to eat cucumber. I eat cucumber, I will get a flare-up. I eat tomatoes, I get a flare-up. It's very, very individualistic. But people are confusing now individualistic dietary approaches and putting it across to grand populations. So this is why we're getting now gluten fear. And people are saying, I get so many of my clients saying, I know I have gluten intolerance. I'm like, please tell me why you think you have gluten intolerance. They're like, every time I eat bread, I bloat. I said, okay, but what about other things that you're eating? Are they bloating? And most of the time they may have a fructan intolerance, and actually it could also be linked with the stress. A lot of my clients tend to find we manage the fructan intolerance, we then manage their stress, and we start introducing foods back again. They're saying, oh, actually, bread was never the problem. Bread wasn't the problem in the first place. It was the stress or other issues. So don't confuse the individualistic with the grand population. But I will definitely say, if you're just looking at, if for the listeners, what should I be typing in terms of a diet? Mediterranean diet, all the way home. We see that in the blue zones. We see that in longitudinal studies. We see that even in vegan and plant-based dietary patterns. Yes, if you remove the animal products, but even if you look at blue zone diets, it's only around about 20% animal-based products. Everything else is vegetables, beans, pulses, and then the lifestyle aspects.
Blue zone areas where people live longer.
So, and this is the thing with blue zones. I have a little bit of an issue with blue zones. The analog is the American population. And we see this problem with a lot of healthcare data. You're always sometimes comparing against a white male population. We see this in a lot of specialities. With the blue zone data, I'm not saying it's not compelling enough. It is strong because you've got a subset of communities and indigenous communities of different ethnic patterns and migration patterns that show you can live up to 100 years of age. And I think there's a percentage cutoff. A certain proportion of people from that community have to have lived up to 100 to be counted as blue zone. But you're comparing it to a westernized American population. And that's where, but blue zone diets, and you're going to hear this a lot, is very much like a Mediterranean diet, but there's a lot of lifestyle elements. So you can't just look at nutrition alone. It's, even social isolation, loneliness, wisdom. There's data now showing that, and again, it's only one study, but this is showing you the path of data and the richness of gut health and the microbiome. There was a study in California of around about 180 people that showed that those that felt that they were more lonely and had lower scores of wisdom had what we call gut dysbiosis, so a favorable imbalance of the unhealthy gut bacteria versus the good gut bacteria. So we are seeing patterns with diet and the gut microbiome with social outcomes and psychosocial outcomes.
Before you go on to the probiotic, prebiotic thing, I want to ask as well, because obviously one thing that's making waves now is the oral microbiome. And there has been shown, there are really strong studies, particularly with gum disease and diabetes, bidirectional relationship that is out there. But now dentists want to delve even further because they're like, wow, this is amazing, because also there's studies now supporting heart disease, atherosclerosis, dementia as well, and things like this. Now, and obviously, as we know, the mouth is the gateway to the gut. Let's be honest, like you forget it's literally like a tube that starts here and goes all the way down. What is your research, what is your views on the oral microbiome? Do you still think there's a lot that needs to be done? What do you understand? And then we can go on to the prebiotic, probiotic, and the oral probiotics as well.
And sorry, before you go, one of the great things about the oral microbiome is dentists can actually
absolutely.
Which
now we know that we can spot things in the mouth and work with people like you or doctors,
Okay. Do I believe in the oral microbiome? Yes, because the microbiome exists existentially, just in everything that we exist in. Where I would say, where I throw caution to the wind is we can't have data and draw parallels and say, okay, by looking at the oral microbiome, we are going to treat diabetes. Because actually we know diabetes is a microvascular condition, it's a multi-organ condition. What it's showing is there's an association, or cause and effect. Now, as healthcare professionals, and sadly it's because the way that we're also presented data is that we love a correlation. We absolutely love that beautiful diagonal line, r squared equals 1 or minus 1, boom, bam, done. Yes, but it's just an association. I could create any association using any statistical program if I manipulate data. And what I would try and say is the data is, we're still growing in that research. There's a lot around the skin microbiome. You can do lots of parallels, skin microbiome, oral microbiome. Are we seeing associations with depression, schizophrenia, other neurological disorders? Yes. But where we need to go is, where does it become targeted therapy and more things like psychobiotics? How can we positively impact the microbiome? I will say, yes, all it shows at the moment is, like you say, the gut is not just the intestines and the stomach. Mm-hmm. It actually has a profound impact on so many of the organs and health outcomes. And what it's essentially showing is that care should be multidisciplinary. Yeah. That I can tell you, as someone that has Crohn's, and when we see IBD patients, and you've probably seen IBD patients, they will sometimes present with bleeding gums and ulcers because of the inflammatory nature. And we know that that's probably also because of a microbiome imbalance. But that doesn't mean by correcting the microbiome imbalance in the oral cavity that they will have less, ulcers and bleeding gums, because we also know it's an autoimmune condition. So with diabetes exists because of insulin resistance. Correcting the oral microbiome is not going to now correct the insulin resistance. It may be a target area to help pre-screening, perhaps. But when you say it's easy to, access the oral cavity and find out the strains of microbiome, we can also do it with fecal samples. But there's 10 to 100 trillion strains of microorganisms. We're just picking the ones that we know from nutritional science have a link. I'm not disparaging this because I love gut health and I love the microbiome, but we've got to be really careful how we interpret this, because we are also custodians of information as healthcare professionals. And it's very scary if we misinform people to the point where we could say, well, the oral microbiome could be a target for diabetes. People will then say, well, I'm spending lots of money with with a dentist who then works with a dietitian, etc. And then they'll say, well, actually, I've now got kidney disease.
You're right. I mean, the important thing is when there is no cure, for instance, like in Crohn's, there's a lot of snake oil salesmen in the field as well.
Yes.
And you're right. As a medical professional, it's important for you to be credible. For instance, I've got family members with Crohn's, right? That you can do a Google search and get 100 different answers and 100 medical and non-medical, nutritional and non-nutritional, 100 different people, because just like anything where there isn't an actual understanding, full understanding of the disease, that there's some, I'd go as far as to say exploitation by some, right?
100%.
And then, to unpack all of that, we need to be cautious.
Yes,
you're
100%.
Absolutely right.
100%.
Right there.
I am not a typical Crohn's patient. I do not. My sigmoidoscopy and colonoscopy looks clinically non-significant. Why am I getting the symptoms? Why is fiber working for me, but certain times that same fibrous product will cause a trigger? The issue is the body and the immune system. It is not innate. It is always developing. And if we look at diabetes and the etiology and pathophysiology, even neurological disorders, we just brandish depression. You have depression, but actually, what is the cause? And I just feel,
and we love masking. I mean, even even now, like people get TMJ, pain, masseters, like all the muscles, and now we Botox it to just mask the pain. It doesn't get rid of it. Think about it.
You're treating the symptom.
Why are they getting the TMJ? Why are they getting the? And then we're just like, oh, let's just Botox it, make it go away.
Like the SSRIs, I guess.
Yeah, but then this is why because as medical professionals and healthcare professionals, we always want an answer. Because we haven't got the answer, I know what it will be. It's probably the microbiome.
Yeah.
Let's now find our next holy grail. Healthcare is always going to be cyclical because we are a product of marketing and scientific propaganda. I know that's very controversial.
I agree.
But I've worked in the world of research and academia. And in that world, it is just as cutthroat as private healthcare because you're always trying to get the next funding round in the next funding series. You want to make sure you get your tenureship. You need to make sure that you are just as relevant as you were now than you were 10 years ago. And the microbiome is a fascinating area because it's a huge minefield that I could particularly find one strain that helps with bleeding gums. And my God, it may be a patentable product. And actually, there could be another 100, 200,000 strains that also contribute. And that's where I always say, microbiome, amazing. I'm going to talk about it till the cows come home, until I'm to that deathbed and that person says, I love you, truly says, I love you. I will talk about the microbiome. But at the same time, when clients come to me, I am not rushing them and saying, please go get a stool sample. I get so many text messages and DMs in my messages saying, where should I go get my stool sample? I'm like, but why? Same thing with continuous glucose monitoring. And I always ask them, but why? Data is sometimes a bit too much and you're trying to individualize and personalize your approach, but you don't even know how to do it, like you've just said. Yeah. It's a witch hunt and of data. I'll pick this, this works, this doesn't work. And that's where I...
So tell me, because part 2 will be coming, tell me then, probiotics, prebiotics, thoughts?
Yes, so I love probiotics and I love prebiotics. Which ones do I love? Natural prebiotics and natural probiotics.
As in food sources.
Food sources.
As opposed to supplements.
As opposed to supplements.
Yeah.
Supplements have a place. Okay, for people that have had colon surgery, so colon resection or colon removed, so they have stoma, if they've been on a long course of antibiotics, or if there's suspected other gut health issues where it's impacting nutritional absorption, where you just want to know, are probiotics worsening or improving symptoms? Probiotics in certain conditions like SIBO, small intestinal bacterial overgrowth, can worsen a condition. So again, we've almost put probiotics as the next holy grail.
On a pedestal, right?
Yeah, definitely on a pedestal. Natural food sources are far better. Kimchi, sauerkraut, tofu, miso, natto. Affordable, you can eat them. So much easier. Prebiotics, the way that I see it is, so probiotics are a source of live organisms, bacteria, yeast, and fungi. They have a positive health and benefit. That's the true scientific definition. I probably paraphrased it and shortened it slightly. Prebiotic is the fuel source for the bacteria. It's what feeds the bacteria to create the end products, the positive end products that we want, short-chain fatty acids, propionate, butyrate, which have positive neuroprotective and gut health benefits. And now short-chain fatty acids do cross over to the blood-brain barrier, so it's not like serotonin. And you can get those from food sources again, onion, garlic, Jerusalem artichokes, the abundance. I always say to people, if you want to learn one tip out of all of this, I know we've gone from love to health to medical gaslighting.
It's all in the gut.
It's all in the gut. But just eat what Mother Nature has provided for us. You are never going to go wrong with just eating Mother Nature's produce. It may sound very hippie, but actually we've learned that from our ancestors, and we're seeing that we're retreating back to those days, and actually we're going to get everything that we need.
In countries where kimchi and tofu are part of the daily diet, are there measurable sort of benefits to the population? I mean, if you go to Japan
if you go to we know that about Japan. We know that the Japanese diet.
Because, Okinawa, they have tofu, but they also have tubers, part of the blue zones. But there are lots of data from Japanese communities that you can then draw over to Western communities that have shown positive outputs of consuming tofu. And because of phytoestrogens and the outcomes it has on overall health benefits, but also reducing long-term outcomes or prevalence of breast cancer, for instance, as well, or cancers. So we see it. The other way that you can draw the parallel is we know what particular strains of bacteria exist in kimchi and sauerkraut, and those have shown positive aspects and health outcomes in an abundance of
populations.
Populations, and an abundance of health issues as well.
Perfect. I feel like we could talk for hours and hours, and I'm conscious of time. Dr. Sunni, it's been incredible. I know as well that you've had, I mean, thank you so much for being open with your own struggles and so forth. The one thing that I want to ask you is, if you could see your 18-year-old self again and you could only say 3 words, what would they be?
Live your authenticity.
Love it. Okay. And I think that you're doing that exactly now. You're such an inspiring, amazing human being. I think I'm going to have to sign up for more sessions. Now I want to tackle the emotional side of the gut. Thank you so much. You've been amazing. I've loved it. Thank you.
Sunny, thank you so much. I want to finish with one last thing. Are there tactics you would recommend? So, for instance, just to explain what I mean, I want to get more salads into my kids. Yeah, I heard somewhere, hey, make the starter a salad before you think of anything else. Yeah, and I used to make a spaghetti bolognese and a salad and just put them in front of them, and you know what
they pick the leaves and that's it.
They'd go straight for the spaghetti bolognese and maybe have a couple of. Now that we go salad first, they have tactics you'd recommend regarding gut
change
health?
Eating patterns or for gut health?
Well, eating patterns for gut health. You know,
I mean, look, strip it back to basics. Don't overcomplicate it. Yeah. Okay, so I always think eat the rainbow, eat the color. Okay, and children, whatever the age,
the more colourful the actual food is,
just all colours of the rainbow. Yeah. Okay, all colours of the rainbow. Think about diversity. Add a tablespoon of fermented foods every day. Okay, or a fermented drink, and that's all you need to do.
Amazing.
Perfect.
3 things: diversity, colour, and fermented foods.
Do you know what my mum used to do? So my mum's obviously a dietitian, right? And she was studied in the States, so she was appalled by the way the UK was treating nutrition. And one thing she said, she was obsessed with building up my microbiome when I was a baby, and I hated courgettes, so she used to blend it with some of the kind of the baby stuff. Food. Yeah, so that I wouldn't know, so that I was getting all the things. So and then that's the thing.
Well, I make a courgette and chocolate cake.
I do.
It's delicious. I've had it.
So, yes, you have.
Next time for part 2, bring it out. Thank you so much, Sunny. Take care. Bye.